All right, hello, and welcome to another Down Fracture podcast, a podcast for talking jaws. Our usual general housekeeping, downfracturepodcast at gmail.com. Feel free to email us any topics, questions, input. We've appreciated a lot of the input we've gotten. I thought it's been pretty on point, Sam. What do you think?
Yeah, I mean, I like hearing from people, so I appreciate it.
Yeah, for sure. So, per usual, Sam and I are here. So, today we're joined by you describe him as special guest. Would you want to
Yeah,
introduce our guest today?
yeah. No, we have a guess that anyone listening to this would already know this name, but it's Brian Farrell. Brian took time at the end of his day to join us from Charlotte, North Carolina. I had the honor of spending a year with him and learning quite a bit about jaw surgery. This was 15 years ago now. And so Brian's been running the Carolina Center for Orofacial Surgery Fellowship in Orthognathic and TMJ surgery for 18 years, something
We
like
are
that.
we are finishing 18.
So quite a number of years. He's a very accomplished orthognathic surgeon, speaks a lot about different topics. And the topic that we're going to talk about today is in-office surgery. Charlotte's one of the spots of the world that has done outpatient orthognathic surgery at high volume for a long time. And so he has lots of hands-on experience in just all the ins and outs of this. So I feel like this is a really good topic because in my practice, the culture in Seattle is still a lot of hospital-based care. What's it like in Arizona?
Similar. There are one recently retired, but there are that I know of two jaw surgeons that were doing a fair amount of in-office. Well, to you guys, the volume wouldn't be substantial, but they were doing some, but a lot of their double jaws and more complex cases, they were still taken to the hospital was mostly single jaws, chins. I don't think any airway surgery. I don't think any substantial TMJ surgery, anything like that was being doing there. So fairly similar to the culture you're describing from my experience.
Yeah, so I mean, I was convinced in fellowship that outpatient jaw surgery is the right thing to do, and that was 15 years ago or so. So I really appreciate Brian joining us because he's super busy, does a bunch of different meetings and talks all over the place. So thanks for coming on, Brian.
Yeah, for sure.
Yeah. Thanks for having me, guys. It's great to see you. It's always been too long, and we may have just seen each other a couple months ago, but it's always too long. So glad
Yeah,
to
no,
be. Yeah.
it's great to connect. I think so I think before we jumped on here, we are talking a little bit about when you guys started doing outpatient jaw surgery. Was it Myron? Did he start it
Yeah.
or
Yeah. I
what is
certainly
it?
have to give credit to Myron Tucker, Dan Spagnoli, and probably our office manager, Danny Catola, who was sort of put in charge of trying to develop the model. And what's interesting is the first jaw surgery case was done in 2002 within our practice. And I bring that up because I was the resident at the head of the bed retracting on the first office-based case.
What year were
So
you?
2002.
No, what year resident were you?
Oh, I was a fifth year.
You were a five? Okay.
Yeah, I was a five, rotating up to Charlotte. And so I held sticks at the head of the bed while we did a LaForte.
Was it just a shit show? Was it just like, or did they have everything set up?
No, no, listen, I don't think it was too bad. And the reason I say that is it was just simply, hey, bring what you always do from a hospital to the office. But I'm not going to lie. Yeah. I mean, maybe at the resident as the head of the bed, I really didn't, I'm like, okay, just tell me where to retract. Right. But at the same time, I'm sure they were probably a little bit more nervous doing it in the office and so forth. But yeah, it was a small room. And just to kind of explain the history of it, I think that back then there was a thought that, insurance was continuing to dwindle. It was harder to get it. The reimbursements were going down. And I do think that some of my senior partners were literally felt like, hey, we're going to potentially lose the volume of jaw surgery if we still have to, utilize the hospital. And so they viewed it as a way to potentially help lower costs and so forth. So that was the impetus for deciding to do it. And then, yeah, just like you mentioned a second ago, it was simple, right? The first time we did it, it was like, let's find obviously the healthy person, but let's do a case that we feel is relatively straightforward. Whether it was a straightforward maxilla, if it was a mandible, but if it was a mandible, the wisdom teeth were out of the way to potentially decrease the risk of unfavorable fracture. And then in the beginning, we tried to limit the anesthesia time to roughly about 90 minutes to 120 minutes, just to say a case that you can get in and do efficiently and so forth. So that's how it started.
Yeah. And so you guys were using the dental anesthesiologist at that time, or did you have a
Yeah,
friend from the
that's
hospital?
correct. We used a dental anesthesiologist out of Ohio State, the Ohio State.
Yeah.
And ultimately, we used a room that was basically a little bit bigger than a dental suite. In fact, it's 14 feet by 16 feet. So it's not a huge room, but we first were doing it by utilizing a dental anesthesiologist. Yeah. Yeah.
Yeah, I mean, I started doing them in my office about 5 years ago, and I mean, I think our first case was a mandible chin, some straightforward thing, and it was all the other stuff that stressed me out, like equipment and just making sure you had all the things that aren't necessarily on your radar when you're just doing it at the hospital, right? So
Yeah, I think that, if a person has interest in doing this, I mean, you have to have the facility to handle it. And once again, it doesn't have to be monstrous. It has to be a facility that is sizable enough, a room that's sizable enough where you can get maybe a stretcher in, or a rolling, one of those chairs that reclines, in and out. But yeah, not only do you need to have instrumentation, meaning power and saws and drills, but you have to have backup
yeah,
power,
yeah,
saws and drills. And you have to have obviously backup suction if that goes down. You have to have backup power in case that goes down. And so it was a lot of emergency preparedness. So it's that initial, like, whoa, here's the cost to put it together, but here's the fact that you need to take it times two, to make sure that you have backups. And yeah, so there's a little bit of an undertaking, a little bit of cost in terms of development. Now, as we continue to remodel offices, or go to new spaces, then obviously, because of the fact that we started to doing more surgery within the office, we had the chance to, yeah, make a room a little bigger. Let's go to 20 by 18. And then, the one that I currently do most of my work out of is 22 by 24. And the nice thing about that is it's spacious enough to hold the arthroscopy tower. It's spacious enough to bring the laser in if you're doing arthroscopy. And frankly, if you're doing a bigger case like a total joint replacement, it must be kind of an important case when not only you have the surgical team, but you have like four vendors in the room too. They must be, oh, not only four vendors also means a lot of cost, because you must be putting in something sizable.
yeah, yeah. I mean, for me, one of the troubles at the hospital, especially at spots where I may not go to as frequently, is just reinventing the wheel all the time. And so a big push to bring it in the office was just so you could keep all the information there and build on it, not only year to year, but like decade to decade, right? Because what you're referencing is doing TJRs in the office, which is very cutting edge. When did you guys start those?
Yeah, so we began to do arthroscopy in the office probably about 10 years ago.
Yeah,
And our TMJ surgeons, John Nail, Dan Cook, were doing, started with arthroscopy, relatively straightforward stuff. Once you get a little bit more savvy at it, then of course surgical arthroscopy. But we intended to deliver that minimally invasively. But then once again, you guys can appreciate the more that you do and the more comfortable you get in your team, the anesthesia team, but your surgical team, it's the same tech every time. It's the same, assistant every time. Again, that's when you start to deliver it and feel more confidence come about. And so in December of 2023, John Nail did the first unilateral total joint in the office, and that individual was discharged to home before noon. And then we did several more unilateral total joints, and just recently made the conversion we have 4 bilateral total joint cases in 2025 that have been completed.
yeah. I mean, that's awesome. I think when it comes to that part, you mentioned that the anesthesia is a big part of it, but don't you think the PACU care is huge? Because
Absolutely. We made the conversion from the dental anesthesiologist to an in-house anesthesiologist. And then about 2 years ago, we have an in-house CRNA, and they're fantastic, absolutely fantastic individuals. And again, every December I collect research on the cases that we perform. And so, over the Thanksgiving break, when I'm sitting at home, I send the same template out to all the surgical teams in the practice and say, do me a favor, it's December, collect the start times for anesthesia, the end time for anesthesia, the start time for surgery, the end time for surgery, and recovery. And so we now have a documentation of how long people are in our recovery room. And you can imagine the variability between some individuals, they'll have a straightforward Lefort and be there 2.5 hours. We have some individuals who have a triple jaw and will go home in an hour and 15 minutes. Um, Anesthesia delivery, fantastic, meaning safe, rapid down. That same anesthesia team understanding the case. I'm a mandible surgery first individual. And remember, that's not why you do it, but it gives your anesthesia team time to begin to work on hypotensive anesthesia, as opposed to, talented individuals who are doing the Lefort first. They're getting ready to down fracture that maxilla in what, 20 minutes after you started, which means it can be harder for that anesthesia team to kind of rush to get the blood pressure down. Well, if you do the maxilla second, then it gives them a bit more time to work on it. But kind of a long-winded answer here. We now put the final, we check the spite. If the bite looks good and we know we're closing, this button goes off, this button goes off. And truly, they're extubated as we're putting the Caramed on and blinking like we're done. But then to your original point, yeah, we have 3 individuals that have been associated with CCOFS in our recovery area for truly 9, 10 years. And so you have them that do just what the hospital does, is a week ahead of time, they're calling and doing the pre-op check. Hey, remember NPO, remember if the case is at 11, you're okay having a little bit of sugar-free Gatorade. You're that way we're trying to avoid the challenges with nausea or vomiting. Work hard to make sure that the stomach's evacuated. Work hard to preemptively give them Zofran, stay in front of it, watching that blood pressure and vital signs. And then, nothing slows down a discharge from your office when you have nausea and vomiting afterwards, or you're too sleepy, or you have a caregiver who's not ready to take over.
Yeah, and I mean, I think for me, I've definitely noticed there's a few key things I didn't appreciate at the time, but a fellowship. But now that I've been practicing in this world, like the black box of dropping a patient off and PACU, like you get them all set up and they look great at the end of surgery, and then you go see them in the ward the next day, and it's like, what happened here? Like, what's going on? But if you're in the office, they just wake up, and the family is there with them immediately afterwards, right? Like, the mom and whatever husband or wife's just right there. And so they see that it's a little bit normal to have some blood out of the nose. And this is what you do if that happens. And, don't worry about these things. And that seems to help people out for safety more than it was obvious to me right off the bat.
Yeah, and it's a talented individual, Ellie. Of course, Sam knows Ellie, but spending time with an individual prior to the procedure, and what I mean by that is not only the patient, but that caregiver who is going to be participating in that first day or two. Really important to have them, here to understand what they're getting into. And then to your point, yeah, there is an advantage early in recovery. Once they sort of come to, their vital signs are stable, they're drinking a little bit, it is to our advantage to get the caregiver by their side so they can observe, they can participate, they can ask questions. And, they start to see the nurse, dab in the nose. They start to see the fact that, the swelling's coming about. It's going to look messy, but the more that we can try and prepare them and get them prepped and ready to go, then we always say, my line is, once you as the patient feel like you're ready to go, and then you look at the caregiver, and when you feel like you're ready to go, then we'll let you go. Meaning not a push, but hey, when you feel like you're ready to go, we'll get you out of here. So yeah, it's important. You take for granted. I take for granted that part of it because that's an Ellie thing, and that's a Stephanie thing, and that's, those people are just really good at helping us deliver what we've been doing here.
Yeah, no, I mean, From a patient side, it's great because then the family sees things. They're not just, in the dark for whatever hospital processes are going on. Are you still having people come by the next day or just in case they have a bad night?
No, no, that's just the way I was taught, and I think it's a great continuity of care. And so that night, of course, we're going to call them. They have the team phone number. All surgeons should have a team phone number, and what I mean by that is, if as opposed to that sort of neutral or classic postoperative phone number, I do think patients and families have a little bit more confidence because of the fact that they're calling team BBS phone number. The same individuals that spent time with them prior to the surgery is the same individual that's going to call them afterwards. It's the same individual you can send messages to at night, the next day. But I'm just a big fan of having people come back the next day, continuity of care. And I tell them the next day is brushing your teeth, cleaning up the mess, answering thoughts, questions you have on your mind, and giving you a pep talk to tell you that, here we go. Everyone's got a little bit more pep in their step the next day, right? First of all, you're on the other side. It's the anxiety. Hey, I'm on the other side. They've also got a little bit extra pep in their step from the steroids we gave them. So there's a tremendous chance to sort of say, okay, hydrate, nutrition, stay in front of discomfort, the team phone number if you have any thoughts or questions. And number 5 is, remember, we're getting ready to head into it. And into it means this precipitous drop is coming in a couple days, and it's not necessarily more pain. It's not necessarily more swelling. It's irritable, grumpy, off routine. This sucks. Why'd we do this? I hate the surgeon. And it's just another chance after the surgery to kind of prep them and reiterate that we're not only here for you, but here it comes.
I mean, we're
Are you doing
describing.
that, Sam?
Go ahead, Watson, what are you saying?
Are you doing that too? Do you have them come back the
I
following
only
day?
have them come back if they need to. I tend to just check on them at night and the next day. Some people come in if they need an IV or something like that for meds. But most people, I mean, the difference in my world is, like parking in my building's a pain and, driving in Seattle's painful. And so there's very like logistics of, I don't really feel like coming down there type of thing. Whereas Charlotte's so nice, you can get around everywhere.
Yeah, and then, people that we all are familiar with the medical tourism side, we have a VRBO in the region. We have hotels close. And so,
Yeah.
sometimes I think there is an advantage to getting people up and moving. Let's get up and move and let's bring you back. And you hit it right on the head. Listen, if they're doing well, we're just going to brush their teeth and clean them up and take that post-op film. But if a person is struggling, particularly with office-based stuff, there's nothing better than, like you said, starting an IV and rehydrating them and giving them a little medicine and giving them some anti-nausea vomiting medicine to kind of relaunch them, so to speak. So I'm a big fan of that, having them come back.
Because I mean, what you're describing just sounds great from just a patient side of having surgery versus the alternative. I mean, it was, within the last month, I had a patient, it was just a single piece of Lefort mandible. I don't even know why I was at the hospital, but I was. And I mean, it was like first case of the day, 2-hour case, something like that. And they ended up spending the night and having a terrible night because they just, they have well-meaning providers, but they haven't looked after patients like that before. And they're doing sign-offs and they have, a lot of the nurse to patient ratios out of whack because, how healthcare is. And we see them next day and they just had just a terrible 24 hours versus what you're describing, which is everyone's in the know. You have everyone looking after you. I think the comparison of those two is so different in terms of kind of patient quality, but also like safety in favor of outpatient surgery.
Yeah, remember, if you go to the hospital, obviously you have very caring, compassionate individuals, but and this, Sam and Michael, it's going back to the same facility that you go. We in Charlotte, North Carolina, have a chance to use 5 different hospitals, but we intentionally go back to the same one because it's the anesthesia team who understands nasals. It's the PACU team that understands, recovery. And then, yeah, my joke is, listen, the nurses in the day are going to be a little bit more hands-on. The nurses at night, I'm not so sure they want to get up and come in and round. And if they do come in and round, blood pressure check, not, you're like, whoa, I just got to sleep. So I think the familiar environment is very key. Back to your own familiar bed, your own familiar couch, your own familiar kitchen, and so forth. It goes a long way just on that going through it side. I'm a big fan of it. And the familiarity with an office. You were here for pre-op, you were here for a consult, you're here I mean, so you're back in an environment that's familiar to you. And I think that that helps people reduce anxiety as best as possible, even though we know we can never get the butterflies and stomachs down to zero. But coming to a facility that, like you mentioned, you don't have to look for a parking place in a major garage because you've never been over there before. And
There's
hey,
a lot of stress to that, actually.
I'm coming through the emergency room, but I'm looking for outpatient surgery. And, there's a lot to be said for those individuals. And yeah, just adding to already stressful times.
Yeah, no, I mean, and so I think a lot of concern in general has to do with the safety of it in terms of doing procedures in the office and like the hypothetical safety versus real world safety. Like, what's your experience been in that
Yeah.
world?
So we were briefly talking about this before we got on here. So because of the fact that 2025 is here, there's a tremendous advantage for people to look backwards and look at 2000. So you have 25 years of data. And so some of my former fellows, Dr. Damling and Dr. Daly, that was their charge to go back and let's start looking at codes and admissions and things like that. And so, yeah, in basically since the end of 24, over 5,000 types of surgical cases, but we're over 2,100 office-based cases now that have been delivered in the office and they have gone home. And in just under 2,000 at that time when we did the studies, we had 15 admissions to the hospital within 2 weeks after office-based surgery. And if you put that number together, that is 0.008% admission rate after doing jaw surgery within the office. If you look at the numbers that were done in the hospital, the admission rate during that period was 36 or 0.11%. Now, you could make the argument maybe the admission rates are higher for those hospital-based cases because we are doing more of the complex there. For example, customization, right? If you're going to do a mandible and customize it, I'm going to generally push that to the hospital because I don't want that increased cost in my office. I want, from a vendor standpoint, listen, charge whatever you want at the hospital, truly charge whatever you want at the hospital. But if we're doing it in my office, I want the cheapest screw and the cheapest plate and the cheapest planning and et cetera, et cetera.
Yeah, you're
So,
talking like a Z or an L or
yeah,
a
yeah.
C
If I'm
ramus
doing a,
osteotomy and
correct,
some goofy complicated plans. Yeah, yeah.
right. So, I mean, remember, if it's a bigger plan, most of the time we're pushing that to the office, or excuse me, to the hospital and not in the office. Now, we do a ton of L's and things in the office, but I'm passing that cost over to the patient. I mean, if we're going to do it here, I generally don't want to absorb the extraordinary cost of customization within the office. But my point is, I'm trying to maybe justify why I think the admission rate from hospital is higher than office based.
But it's not higher in the outpatient, right? Like I think because
Lower.
you do complicated cases in the office because I at least remember
Oh yeah, yeah. I
your
mean,
submission
there's
for sleep apnea, right? Like MMA
yeah
as
we
outpatient and it got
yeah.
rejected or something. Like there's some
Well,
story.
yeah, we started to do during again, Adam Fagan and Wendell Mascarena's former
Maybe
fellows
that's who I heard it from.
went back and looked at I think we have almost 40 diagnosed obstructive sleep apnea patients, triple jaws that we've treated within the office who have gone home to their own couch that same afternoon. And listen, I want to stress to your listener, how many you have? One, two? Um, touch of a joke, touch of
I
a
think
joke.
there's three. I
Okay.
mean, we've been at it for a while now, Brian, man. It's
I know.
legit.
I know
I
it's,
would describe our listening or base as a cultural phenomenon at this
I,
point.
by the
More than
way,
anything.
I've been listening and I think it's great content too. Point of this is what I don't want to come across as being pompous and arrogant. I don't think this is for everybody. I don't think it's for everybody. But, we tried to put a study at that point with Adam and Wendell to the journal. And all we were trying to do to the journal is to de-escalate the thought process that people with obstructive sleep apnea and maxillomandibular advancement surgery had to have inpatient monitoring. All we were trying to do is say, listen, we believe that you actually can send individuals home because we all appreciate if you take a post-op day one scan, we know that the airway has gone from the size of a pen is now much, much bigger than a garden hose as we change the scaffolding. So we're not trying to ooh and on anybody. We were just trying to put it into literature because it belongs in the literature to de-escalate that people don't need intensive care monitoring after triple jaw surgery or double jaw surgery for obstructive sleep apnea. The point is it was just like literally like, well, this is nothing. And we're like, oh, well, thanks. We actually think it is something.
Well, yeah, I
And
mean, I don't think it's a great idea to choose your first outpatient surgery to be a triple jaw and sleep apnea, BMI is 40 or something. But from a standpoint of, when I did fellowship interviews, I interviewed with you guys and then Stanford, and it was the sleep center at Stanford. And those guys were saying then that everyone had to spend a night in ICU, right? Like there's this conventional wisdom that's really hard to overcome when it comes to anything we do. And one of those is that sleep apnea patients do best if they're monitored. And basically, the things that you've been saying are true for all patients, independent of the sleep apnea business. Like, if we can care for them better ahead of time and after, I think it'd be great. It makes sense to do it.
Well, that's the issue though, right? I mean, their preoperative care should be what's concerning, right? If they're a difficult bag mask, if they got a lot of facial hair, their BMI of 40, like you're saying, like that post-operatively, they should be better. Like, I mean, I could understand the concerns about intubation and, those saying, okay, maybe we're safer in the hospital, but post-operatively, I mean, you should have made them better.
yeah, I mean, and by the way, the big asterisk, remember, we started doing this in 2002. So,
Yeah,
right, we were
totally.
doing the straightforward Leforts, we were doing straightforward mandibles, chins, that type of stuff. And then, again, as the team becomes more competent, you become more confident in the anesthesia, then it began to grow. Double jaws come in, segmental maxillas, atypical subapical cases. I mean, the point is, over the years, we've allowed it to basically become, we feel fairly comfortable doing just about anything in our office. But yeah, that's an evolution over 2 decades. Nothing that we would right out of the gate say, hey, I'm going to tackle that in my office. That's not smart. That's not common sense. But I'm very fortunate now in the position I am that I don't decide where it's done. I have the ability to basically tell the family, I'll deliver the care anywhere you would like the care, but it comes down to two major factors. One is where you feel comfortable spending the first night. And two, unfortunately, this is a huge logistic. It's where you get the best coverage to have the procedure done. And my coordinator, Stacy, who's fantastic, can basically put it together, and Stacy and the family decide where we are going to do it. And
Hmm.
so that gives me a little bit of reprieve. Okay, tell me where I'm going to do it. But at the same time, in our 25-year study, we were at 40% of the cases of that over 5,000 were office based. But in the last 10 years, looking at those numbers, it's gone up to 46%. The last 5 years were over 55% were office based. And if you look at literally the last 2 years, it's almost 65%.
I mean, my neck of the woods, people just don't want to go to the hospital. Like
Yeah,
they just, I
you're
mean,
sick. People are sick.
COVID business, it's just like, I don't know if people are just turned off by the hospital systems or what, but it definitely, I definitely hear that as well. Wasson, is Arizona, everyone's just like, I love hospitals.
I don't think that they know differently. I mean, again, there hasn't been a huge volume of in-office jaw surgery. It's come up a couple times where, again, a colleague was maybe going to do it in office, and I was going to take it to the hospital because that's how we were set up. And you're at the whim, especially if they're cash pay, you're at the whim of what the hospital charges cash pay patients. And you don't have any wiggle room or anything like that. So I mean that has come in the decision making a couple of times, but I'd say the majority of people here just expect to go to the hospital.
Sure.
I was going to ask you, Brian, about some of those trends you mentioned about the percentages of in-office versus hospital. What do you chalk that up to? Is it, as you've mentioned, the increasing comfort level both with your team and the anesthesia team? Is that cost? Is it a combination of those two things? Are you seeing trends in cost and reimbursement that are driving it to your office, or is it familiarity and all that
Yeah,
stuff? What would you
I
attribute that to?
yeah, I think that's a great point. So remember from the standpoint of insurance and the reimbursement side, unfortunately, we all know that we have to work so hard to get approval for cases through third-party providers. We've just heard that they now have unleashed AI, and AI is just all over submissions and all over codes and all over. Basically, they're working to say no, and that's nothing that this podcast team knows all about. The answer is no, 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 and you've got to prove medical necessity and so forth. So again, circling back years ago to the CCOFS model, we ultimately would deliver cases in the hospital and we would ask people for their itemized hospital bill. And so we would collect 5 itemized hospital bills during the summer months. And then we would deliver, 5 or 10 cases within the office. And then that allowed us to take the EOBs of hospital and EOBs from our office space and go back to begin to talk to the third party providers. And by the way, that didn't happen overnight. That was literally this long, arduous process. But ultimately, over the course of years and years, we now have allowed, or that we've got anesthesia teams that are comfortable with it. They will actually come in and help staff our office because they know it's safe and so forth. But maybe circling back to the insurance side of this again, real quick, they now have, okay, here's facility fee, here's, a decent surgical reimbursement. And so we now have been able to basically put patients to say, we can do it here. You're still getting good insurance coverage and it's saving patients money. So I think that has been probably the biggest impetus is we do a lot of cash pay, but we still continue to file quite a few third-party insurance submissions for people, and we have the ability to do it here and get reimbursed. It's been an evolution. Yeah.
Yeah, because over time, because I know, and correct me if I'm wrong, but I know there's a couple different ways that practices go. One is to build separate facility, get licensed with the state, get your own tax ID, contract with insurance as a facility, versus have the dual professional fees, like the facility, non-facility professional fees broken down. Were you guys always the same throughout the years, or did you do the professional fee model and then switch, or how did it work over?
Well, it basically came down to, whatever the insurance company was comfortable doing. And what we mean by that is, listen, if you want to bundle the surgical fees and the facility fees into one reimbursement, we're fine with that. But remember, the numbers got to be,
Yeah,
here, right?
yeah,
We'll break it down any way they want to break it down, but yeah, it's just making sure you're getting good remuneration for what you're doing. And if a person does not have very good reimbursement, then those are the cases that are, of course, going to be pushed more to the hospital side. But yeah, we're fortunate to now get, through several insurance companies. We don't accept all of them. We still bill, or excuse me, we'll still fight for those individuals that are out of network, quote unquote. But remember, those individuals oftentimes are going to have to pay up front, and then we're going to work hard to try and get the money back in their hands, meaning after the fact. But a lot of times with several of the insurance companies that we're involved with, they've come to the table through a long evolution and actually will pay, 85% of our billed surgical fees and 85% of our facility fees. Our TMJ surgeons, it's ridiculous
yeah.
how
No.
well they do.
Yeah, I mean the long-term relationship with insurance is because I would imagine most people that are listening to us are kind of more on the beginning of their profession, and like how do they start doing this in the office, and because growing something 25 years later, is it's hard to have that horizon, right? Like it's like I'm going to do one of these cases in my office, and I tried to come up with a financial case for this. So accounting for the long-term relationship evolution of insurance companies is a difficult one, right?
It's,
Um,
and by the way, um, uh, you two as the surgeons, that you don't have time in your day to go fight. And that's why it's so advantage, to have people behind you, meaning the Danny Catola, who I could say, Danny, take this EOB, take this EOB and go talk to the insurance company, as opposed to it's not on me to go do that. Or, it's just, that's where the cost of doing business has gotten so high, right?
yeah.
You need those coordinators to help you submit the claim to start, but you need the people on the back end to make sure the billing's done appropriately. The cost of doing business continues to go up, and yeah, you have to have those trusted individuals that are continue to kind of knock on their door and meet with them, and hopefully illustrate the fact that it is safe. And by the way, we're going to get this data into the literature, because if this data gets into the literature, now other anesthesia teams, other hospitals can now appreciate the fact that it can be done. You can go home. You don't
Man,
have.
I would even add in there if you can if you get some of the insurance data in there because I think that's our fight, Sam. And I know you live in this world, but like it took you guys 25 years of evolution to get where you're at, but it shouldn't be that difficult from an insurance standpoint because it should be more financially viable for everybody, right? Like the insurance should pay
I
less
mean,
potentially.
it seems like everyone's interest is aligned in what we're talking about.
In
Like the
doing
insurance
office-based
company, the
surgery.
patient, the
Yeah.
provider, seems like everyone's on
So
the same page here.
yeah, I have this talk. I mean, this talk is basically the thing is, everyone's paying more and more for premiums with their insurance company, but yet when you need it, it's no, no, no. And why is that? Because the CEO of Cigna just retired and made like $90 million. I mean, insurance is a business. They don't want to pay out, but you're right. Orthopedics is now taking hips and knees to surgery centers. The people are getting out of the hospital. And so, and this is another important part of it from an oral and maxillofacial surgery standpoint is, remember, hospitals, I personally think hospitals they want to do ortho, they want to do cardiac transplant, and they want to do cancer. But they don't want your mandible fracture. They don't
I
want your
agree.
infection. And it's
That's
so
exactly right.
hard for oral surgeons to get block time at these hospitals. There's where it's going to potentially be even more challenging for individuals to get time to go do their orthognathic case. By the way, an orthognathic case in the hospital is very profitable, but when you go over for the hospital is what I mean. But remember, you can't go over and do an orthognathic case that takes 6 hours. And I'm not trying to badmouth anybody who takes that long. I'm just saying, remember, you got to go over and be profitable and productive and be efficient. So when you go use that block time, you're doing two cases. They're more amenable to take you at the hospital because they have all the stats on you. Oh, here's Farrell. We know that's going to take 3, so he can do 3. If you go over and don't do it very often, and you now said you're going to take 3, but it takes 6, they're not going to be as kind to you the next time it comes around for block time, or you want to add the second case, because more and more hospitals, in my opinion, are becoming more and more like ambulatory surgery centers, which means at 3 o'clock, we go down to 2 rooms. And at 2 rooms, you're now in line with the emergency lap chole, and so forth. Whereas, again, put it in your office where you have the autonomy, you control the schedule. Um, you can decide when you want to do it, the day you want to do it. You can share with your partner. They can have a TMJ day, you can have a jaw day, you can have a full arch day. And basically, the point is now the team's locked in. Today's jaw, or today's joint, or today's full arch, or whatever it may be. And so our anesthesia team, there's not they want a day off. We're like, no, 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 no. We got to make hay. So if you want to take a vacation, please do it in the spring or the fall, because we have you accounted for in the summer and December.
Yeah, I mean, I think everything you're saying I mean, this makes so much sense in terms of being able to pull it off and carry out a kind of best patient jaw surgery practice. It's just kind of getting people from one model to the other, right? Like joining a practice like you guys is an easy, not easy, but like that's like conceptually easy. You're telling your fellows when they go out into the real world, what do you tell them?
Well, listen, the good news is, I do think that a lot of the fellows are going out and obviously they have a passion to spend a year with us to, and by the way, everyone obviously from a fellowship standpoint comes from great programs and training, but I do think the year to improve surgical efficiency, understanding on planning, but learn the model. And what I mean by model is learn the billing and learn all that sort of stuff certainly helps. But, for example, just this past year, Blakeney, where I work in December, wasn't the busiest outpatient surgery center. It was Verde, where a former fellow now works. And so we believe the model is scalable. The model is scalable, meaning it's not just Charlotte, but we have these in Raleigh, North Carolina. We have them in Columbia, South Carolina, Greenville, South Carolina. So I think the model is expandable, but it's really going to help to be expandable in a market where we can help bring insurance contracts, which means the Southeast, North Carolina, South Carolina, Virginia, Florida, etc. If you're out and about, like for example, a young uh, uh, graduating resident or someone who's a junior surgeon, yes, it's an uphill battle if you're trying to do this on your own, or you're joining a practice where you've got a friend. That's maybe going to be easier, but it's going to be hard to get it up from scratch. So I wanted to circle back on the fact that what you said, yeah, listen, I'm very fortunate and I can speak about it because we have a model and I wasn't the one that got the car started, but I think I'm the one that continues to help put gas in it and keeps it rolling. But, remember, I think that making sure that the community, the hospital, and everyone understands that good, solid care can be delivered in an office environment. And we as oral surgeons we can do beyond dentoalveolar in an office. We can do TMJ, we can do jaws, and it just takes smart, just smart model, smart plan, good execution, but put your head down and keep it going because it will pay off, I think.
Yeah, I mean, I think it's all great advice. My last one, because I just went through this process, which was Triple HC. Are you guys still using that certification, or where would that fit in the spectrum of supporting your outpatient jaw surgery practice?
Yeah, so to that point, yeah, I know that you just got Triple HC accreditation, Sam. That's awesome. But listen, in the beginning, I thought Triple HC accreditation was important to help families understand that we're not doing this in the closet, to help families understand that you're in a facility that is now being held to standards and so forth. And I think we all thought that was very, very important in the beginning. I also think we thought it was very important to have Triple HC accreditation in the beginning because of the ability to bill facility fees. I don't necessarily know if that's actually still necessary to bill facility fees. I'm not, listen, forgive me. I'm years into this, so I don't necessarily think or know if our insurance contract at present requires us to be Triple HC accredited anymore. Does that make sense? Now,
Yeah, no, definitely.
we're not giving it up, but my point is, if we weren't Triple HC accredited, would the insurance company still listen to us? Maybe they would, but maybe the Triple HC designation just helps show you're serious about it.
Yeah, and
Uh,
I think
but
it's also good for anesthesia, right? Like, I mean, because anesthesia providers, they don't want to go somewhere that doesn't have like backup power, or they're just. I think
yeah,
it helps those big groups.
no, I think it's huge. I mean, no offense, but you don't want to. Like for example, if you're a mobile anesthesia team and the mobile anesthesia team goes to the pediatric dental office, they go to the urology office, they go to all these places. I tell you what, there's an advantage to having a little bit of appreciation for the fact that the facility is up to snuff and
Yeah.
it is held to those standards and it does have backup power. And maybe the all-encompassing word is emergency preparedness, right? When things go wrong, is the facility going to be ready to handle that? So yeah, I wouldn't, I think having Triple HC accreditation is very advantageous. I'm just being honest at this point. It's rarely brought up. It's rarely brought up to me anymore. And what I mean by that is, in the beginning, maybe I didn't have gray in my beard. As I was talking to people about doing this, they were like, "What? You were doing this in the office?" There was the chance to bring a line or two in that, hey, we're accredited by the same organization that accredits the ambulatory facilities, and we're held to those standards. And maybe that helped to dispel some of the fear. At the same time, in our office, I think they walk in and they see it hanging on the wall when they walk in, and maybe that dispels it. But I also think it's very easy for us to kind of bring up our track record. But if you're an individual that's maybe trying to break into this, it's only going to help, I think.
Let me loop back in. There wasn't a large amount, fractions of a percent basically of people who had to be admitted despite having the surgery in your office. With such little data, you may not have much of an answer for this, but were there any trends to that or common factors, commonality in that? And did you find anything that maybe influenced who you will and won't do in the office because of that?
Yeah, I think it's a great question, Michael. Interestingly, no. I mean, listen, to be honest with you, I think you guys may appreciate this. I actually think the young ladies are far, far tougher than the guys. Um, and so
Like
maybe
they
the
can put up with
guys,
surgery more, is what you mean, right?
yeah,
Yeah, yeah.
yeah. The ladies are tougher and just seem to be much more adept at recovering and bouncing back than the guys. The guys seem very soft, in my opinion. And we have three guys on this podcast. We're pretty soft. But, what's interesting is, a lot of those admissions, those actually included just hydration or pain management or a caregiver that wasn't prepared to handle them. And okay, we'll put you in the hospital overnight and we relaunched them the next day. So, I mean, even in those numbers, it's not all medical emergencies or anything of that nature. But remember, listen, unfortunately, you get a pseudoaneurysm. Well, a pseudoaneurysm can happen whether you did it we all know it didn't happen during the procedure. It happened on Saturday night when you did the case on a Tuesday. It didn't matter if you did it in an office or it didn't matter if you did it in the hospital, because at that point, everyone should be home. But those numbers include everyone that went back, whether it was infection, whether it was, needed to watch from bleeding post-op versus truly just needed some hydration. There's where I think you can keep the numbers down post-op by being ready to see him the day after, to truly rehydrate him, to truly tank him up, to truly give him a little bit more TLC.
Are you saying that in the context of mentally the patient knows they're going to be seen the next day, and so maybe their threshold for panic or reaction is less? Is that what you mean by that?
Yeah, I think that, listen, maybe, and for, listen, at 1 o'clock in the morning, it may be to my advantage and it may help decrease admission rates because the caregiver may be able to look at that individual and say, hey, we're seeing Dr. Farrell at 10 a.m. You know, hey, let's hold on. Let's give you some more medicine. Let's see if we can get you some sleep. Here, drink a little bit. But the fact that they know they've got an appointment in the office who knows? I don't have that information to know, how close were you to actually pulling the trigger and
Right.
going to the ER or so forth. And so, yeah, the fact that maybe you see them the next day may be very helpful for those individuals who are struggling the first night.
I mean, we all have kids. I feel like that's totally true, right? Like, I
Yeah.
mean, if you knew there was some backup plan and it was a short-term thing, that'd give you comfort versus the unknown, which can cause anxiety and lead to more phone calls and all the rest. So,
Yeah,
Well, that was going to be. I'm sorry. Go ahead.
no. I was just going to say, remember, huge props to that person who is truly there, Ellie, in my situation. who's there truly to help, navigate these people through their first night or two or three or four or so forth. Now, what's interesting is, I don't know, as of late, more and more people are abusing it. Listen, if you're a teenager and it's 1 o'clock in the morning on a Thursday and you're not asleep, well, if you're 2 weeks out, you shouldn't be reaching out asking why the orthodontic hook is poking you, right? I mean, that's abuse, right? But at the same time, getting a person through those first few nights and get them when they're in the valley, just hang in there and pep talk type stuff. Um, that person's worth their weight in gold. And I will tell you, I would venture to say the number of admissions would be much, much higher if you didn't have that individual who met them prior, spent 30, 45 minutes with them prior, however long it takes to answer their post-op questions beforehand. As the pamphlet's being reviewed, that's my number, that's the team phone number. So listen, I don't have that data of how many people Ellie prevented from being admitted, but boy, it's probably quite a lot.
Yeah, man, I feel like we could talk to you all day. You got some great stuff, but like our podcast and attention span of our listeners and my own is probably pretty small. But I do have a couple other questions, hopefully, that I
Please.
can
Yeah,
get
yeah,
in
yeah.
here. So one of them
Have another
is
sip of beer.
oh man, now you got me distracted and I forgot my question.
That's all
Um,
right.
do you can you speak to the discussion or lack thereof of hospital admission as a backup plan? Do you guys discuss that and say, hey, we have this available if we need it? Do you find that maybe that tips the scales towards them going that route? Can you speak to that at all? Like, do you not even bring that up in hopes that maybe that's less on their mind and maybe they don't want to push towards that happening?
Well, I guess the answer to that is we have a very good relationship with the hospital that we operate at and where we take every bit of facial trauma and an infection from. Sam got nauseous when I bring up the name of University Hospital, but we have this great relationship to where even if I do it here, if a person has an issue, there won't be any problem with me sending them over for a bed, almost a kind of a direct admission. But in terms of talking to the family about it, um, no, not prior to, but if I thought they were struggling, I wouldn't have any problem. It would never
Yeah.
be, oh, come on. It would never be like, oh, come on. It would be, okay, listen, if you're going to feel more comfortable, more than happy to get things organized and set up for you to go over and get some fluids and get some medicine and maybe have some nursing watch over you. But because of the fact that we've spent all this time with them prior, I don't feel like I have to bring that up unless, after the fact, I need to talk to them about it.
Did ballpark, does that happen yearly or like every 5 years, or
What's that?
someone actually electing to go back to the hospital right after the surgery?
Yeah, once in,
Like
yeah,
never.
once in 5 years. Although, listen to this, just had an admission over the December period, straightforward Lafort, but prior to intubation, she was actually having little retractions. And so we did the case and it took us routine time. Afterwards, having trouble holding saturations and truly felt like she probably had a little, negative pressure pulmonary edema. Watched her nebulizers, things like that, with our talented PACU team, our anesthesia team close. And, as opposed to that, letting her go in 90 minutes or 2 hours, like I mentioned in the onset of this, we watched her truly for about maybe 4 hours or so forth, just to see what she was doing. And, we, with on room air, we'd get her up to like the high 80s, maybe low 90s, if she truly took a breath. And we just simply said, you know what, it is going to be better if we let you go and be monitored and so forth after the fact. It was the worst thing we could have done because she went to the hospital and at that time they didn't have a bed for her. So they suggested she go to the ER while they wait. Well, what did the ER do? Well, the ER saw that she had
CT scan.
tachycardic, and because she just gotten some albuterol treatment, she's post-op. Our ER gave her 3 liters of fluid. you can only imagine what happens now. And so the answer is we had too many cooks in the kitchen. This young lady, had she gone to the floor or had gone to maybe, I'm not going to say home, but my point is she goes, gets the absolute wrong treatment, and now ends up getting re-intubated for a couple days because of the fact that now she has so much fluid in her lungs. So listen, that happens. And that's an admission, and not saying it's not, but that's um, just, a fluke and a young, healthy patient. And then this is healthcare. So she's intubated for a couple days. And while she's intubated, they, give her fentanyl and things like that. While she's intubated, well, she's now extubated, and now they have her on anti-opioid de-escalation protocol. So she comes in just absolutely zoned for like 10 days while they're getting her off the fentanyl treatment that was used while she was intubated. And it's like the last thing off a dying dog, a flea. It's like, whoa, just, this is what it's, if they would have actually checked out to us, if they would have said, anyway, the point is stuff happens, shit happens. Young, healthy patient wasn't a big
Is that an
deal.
old man saying there? Did we
Yeah.
get that one, Sam? Did you?
Yeah.
That's like, we have to have an old man saying in every
Yeah, you got to
thing.
have an old man saying, but point
I
is,
mean,
it happens. It can happen. It can happen. Nothing surgical in that situation,
Right.
but it was an anesthesia thing. But once again, wouldn't hesitate at all to send a person over. We're not brazen or anything like that, but at the same time, got in the hands of the wrong team, and it was just it
but
now made a hospitalization that was much longer than it needed to be. In my opinion, some Lasix, 24 hours, get it out of her lungs, and she probably would have been over the next day. The problem is we flooded it. Not we, but the wrong person got a hold of her.
yeah, I mean, what you're describing is it's why I think it's better in the office. Cause I mean, jaw surgery is a weird thing, and seeing people after surgery is weird experience to have, but you're hanging out with all the people who have that experience, and that only helps you out. I mean, getting fluid after that isn't an obviously bad thing if you're an internal medicine doc, like my wife's internal medicine.
Yeah, I
To
know.
them, it's like totally reasonable. And I get it. It's just in this subgroup, it may not be the best idea. So
Yeah. So, and remember, the from the standpoint of having the intensivists and the hospitalists, and they're all important. At the same time, a young, healthy individual that likely, if we go this way, it's very simple. If we go this way, we've made it much harder. And having those individuals that are knowledgeable and know about intubation and understand our patient demographic. I tell this to every family in preparation for jaw surgery. I tell them, remember, if this surgery is on your belly or on your elbow or on your knee, it's covered by bandages, it's underneath the blanket, gowns. Remember, we can't hide what we do, and it's out in the open. And, again, it's going to look like you've been hit by a truck. But at the same time, all those things that exist on a consent form, it's scary to everybody, but good, talented surgeons, like this team on the podcast, the answer is we can get in, do accurate surgery. We can stay away from where we're supposed to stay away. We don't have challenges with blood loss. Infection rates are low because we have good perfusion. And we all realize with good surgery, most of the time, our post-op patients are going to go down relatively the same path. Every now and then, one gets outside the guardrails, and seeing that and bringing it back into the center is important. But um, I still think delivery in an office where you stay where you're supposed to stay, be efficient, be methodical. You can do great care in your office, and as opposed to eating chips and Diet Coke in the doctor's lounge and watching, the news channel that one doctor has chosen to watch that is, whatever. I can, in between cases, you can make calls, you can trace, you can plan, you can see post-ops. It's so efficient to have it in your own house.
Where
Wasson,
did what
Wasson, why aren't you doing it? What after this? Are you gonna make it happen finally? Because I've been
he
harassing him for a while about doing this in his office.
Brian makes a better case than you. He's also arguably more
That's true.
handsome. Um, Yeah, I mean that's always been the goal, but sometimes it's a volume thing, it's a systems thing. There's some we've gotten the ball rolling, but we're nowhere near where you guys are, especially Brian's group. And that leads to my next question, Brian. In your group's experience, where did shit go south? Like where were the hard lessons that you guys learned that some of us who aren't there would go, wow, if I could have one, two, three things that I know I should not do that maybe I think I should, or vice versa. Where did your group notice that, if at all?
Yeah, no, I think that it's important that, remember I mentioned I'm the gas. And so, I was plugged into a machine. So I had the people in front of me that were, able to say, oh, that's definitely a hospital case. You shouldn't try and do that here. I think most of it is probably common sense type of stuff. And by the way, we have an unbelievable anesthesiologist, Schmitty Lineberger. And honestly, Schmitty he'll do patients that probably we shouldn't be doing here, meaning he's that comfortable doing it. We have, a CRNA, Lisa Hood, who's with us now, who's unbelievable. In fact, I take December information and I look at anesthesia delivered by my MD and I look at anesthesia delivered by my CRNA, and there's no change. I mean, you could blindfold it, but that's because of the fact she's been with us for 3 years and our doctors are becoming more and more comfortable with it. But I don't necessarily think, Michael, in our opinion, it generally is not the jaw person. You know what the biggest issue in my practice is? It's our all on four docs who are trying to do it on the 75-year-old individual who is a step above a 4 on the ASA classification because they want teeth and chew for 10 more years. So rarely do I get the question from the anesthesia team that's doing the pre-op, screening for us. Most of the ones that we're doing outside of the OSA are generally fairly, in the decent health range on the orthognathic side. The TMJ side, again, you guys do the TMJ stuff as well. I named it the TMJ stuff. But the point is, remember from a surgery standpoint, and you think about fluid and such, we're fortunate it's lateral, so it's not going to be airway issues there. It's going to be more potentially getting into bleeding or something of that nature, which again now comes back to good anesthesia, but also good surgical techniques and experience. So, if I had to say, most of the issues that we've run into, admissions, by the way, that are not listed under my orthognathic admissions, because I'm not taking blank partner in my practice who sits 2 desks next from me, their admission to the hospital after an all on 4, because, well, it's going to make my studies look wrong. I'm joking there, but you know what I mean. You know what I mean. It's a totally different animal than the orthognathic. So just good patient selection. I probably I don't know. Sometimes I'm like, what am I doing? That doesn't come around too often, but yeah, usually we've done a pretty good job. Now, I did tell you sometimes earlier that my assistant, or excuse me, my coordinator and insurance will help decide where they do it, the families, etc. Sometimes I'll kind of walk in and be like, final records, I'll be like, wait, we're doing this in the office? What, why was that? Oh, this reason. And most of the time, even though they may be a little bit on the overweight side or something like that, there can be a justification because of the fact that they don't have very good insurance and it's more of a cash pay. We may be willing to kind of stretch it a little bit on those types of cases, but that doesn't come around too often. But anyway, sorry, very long-winded way of saying, yeah, I've been there and done that, but it doesn't happen too often.
Okay, cool. You got anything else, Sam, or should we wrap this up? It's already
No,
been.
I think it's great. I feel like this is our longest episode, but it flew by. It's always good to talk about this stuff. And Farrell's got such great experience on this. It's great to pick your brain a little bit on it. So I really appreciate you sticking around after work.
Yeah,
No. I'm happy to do it. Listen, like you two, I'm passionate about it. I want the oral surgery community to deliver orthognathic surgery. I want the oral surgery community to kick ass in their community. And so I'm really passionate to make us as a specialty as sound as and solid as it can be. And, I always tell people if I can help in any way, I'm happy to help in any way to make sure that we are the best.
awesome. Well, yeah, thanks for coming on. I mean, I think we should have him back maybe every week.
Listen, I'd be
Kick
more
us
than
off the
happy.
podcast.
I'm here. I'm here. So if you guys think I have something that maybe educational for you or controversial for you, don't hesitate to let me know, and I'm happy to participate. Great
Yeah,
to see
and
you guys.
go Houston Cougars, right?
I don't even.
That hurts.
Oh, I don't even know what to think. I may not even turn the damn game on. I may not even turn the damn game on because
Too soon, too sore. Sorry.
oh yeah, it's okay. It's all right. But
Hobby's junior? What's she had to do?
Poppy's a sophomore there. Yeah,
Sophomore.
she's a sophomore there. And
That's
so
wild.
yeah, I'm a Midwesterner, but yeah, I now pay tuition at Duke, so I've become a Duke Blue Devil.
Oh,
All right, man. Well, thanks a lot for
yeah,
joining us.
thanks again.
Yeah.
Thanks again, everybody, for listening into another Down Fracture podcast for Talking Jaws, downfracturepodcast@gmail.com. Thanks again to Dr. Brian Farrell, and we'll see you guys next time.
Thanks, guys. All the best.